For this lecture, we'll begin looking at our ventricular dysrhythmias. So we're going to look at premature ventricular contractions, so our ectopic beats. We're going to look at our VFib, VTach, and we will talk about the differences between a stable and a non-stable. And then to kind of finish off just this lecture, I'm going to talk about pacemakers, and then we will get into heart blocks and asystole in the next short lesson. So when we talk about our ectopic beats in the ventricles, we're talking about PVCs, and we know, we've talked about the fact that those beats are not a rhythm themselves, so they come with an underlying rhythm. Instead of being early and having a skinny QRS, you will notice that these have a very wide, bizarre / distorted QRS complex. Remember, the QRS is the ventricles contracting, and that's what we're seeing, is we're seeing an extra beat of that heart. You have various types, so it sounds really intimidating. I promise you it's really not. You have multifocal, unifocal, bigeminy, trigeminy. You've got couplets, triplets, and of course you've got this risk for R on T phenomenon. Again, PVCs, PACs are a early warning system. So they're there to tell you that, hey, I may have something going on that you need to investigate. So you're going to look at their electrolytes, you're going to look at their MAR, assess their vital signs. Remember, hypoxia can lead to dysrhythmias. Just making sure that your client is still stable, because once we move beyond triplets, so 3 PVCs in a row, you start having runs of ventricular tachycardia. And you can guess that if you leave that untreated, that's going to turn into something more significant. So this is our first example, and what I want us to notice is that we do have an underlying rhythm. So starting here and working left to right, I'm going to look for an atrial rate and I'm going to look for a ventricle rate. We know that these are going to be different because I do have a couple of PVCs. So we know that there would not be a representation of the atrius contracting because this ectopic beat is originating in the ventricles. I do see this wide, bizarre, sore thumb appearance. I do see that it comes earlier than I would have expected to. I kind of would have expected it to come there. And I also have a compensatory pause. Now, the thing that is special about this sinus rhythm, because it is still a sinus rhythm, heart rate, I believe, is somewhere between 80 and 90, we're going to count these extra beats because, again, it's still the ventricles contracting. So, sinus rhythm with, and now here's where you can be high speed or not high speed. It's not going to matter for basic nursing. But these are unifocal PVCs. So you can say unifocal PVCs. You can just say with PVCs. You don't even have to say with rare, with occasional. You're just telling us that this is what we are looking at for this 6-second piece of time. Again, it looks scary. Most of these things can be corrected by either looking at the MAR, checking the electrolytes, getting a set of vital signs, making your clients more comfortable. And again, they're in the hospital, they're going to be stressed, and it's a total normal reaction to stress as well. So that's why we're going to continue to monitor this rhythm with its ectopic beat, or beats in this case. So una means one. Just kind of break it down here real quick. We said it's going to be a signal originating in the ventricles. So generally speaking, because these do look fairly consistent with one another, we have the SA node up here, you have the AV node right here. So once that system fires and you get these QRSs, what's going to happen is you're going to have another area in the heart, in the ventricles, that is going to cause this adherent signal to come earlier than we would have wanted it to. But your heart wants to beat in a rhythmic pattern. Whereas this one, I do see that I have a wide, bizarre QRS here. Right? The red boxes are there to show you that you're going to measure, and it's going to be bigger than your normal 6 to 12 QRS. So it's wide, it's bizarre. Now, what we do notice is that it's still a sinus rhythm, and then we have two PVCs that are going in opposite directions. So obviously this one goes this way, and this one goes this way. I now have a sinus rhythm with multifocal PVCs. But again, you can just say it's with PVCs. And that would be good enough for basic nursing. On this client, and you guys know I love these because these are real clients. They are trending towards having very serious issues. So what we've done here is we've kind of marked out our PRIs here, because that is still part of the toolbox, and I need to use the toolbox just to make sure that I don't have any heart blocks or anything that may be a precipitating cause of what's happening here. So then what we're going to do is, because this is a continuous tracing and not just a 6-second strip, we're going to get roughly 6 seconds worth of information. I'm not going to actually count 30 big boxes, but what I do see is I see a heart rate, or a ventricle heart rate, of 1, 2, 3, 4, 5, 6, 7, 8. So around 80 to 90-ish. My atrial rate is much different, because every time I have a wide, bizarre QRS, I don't have a P wave. So what I want to look for then is what kind of pattern. And these are our patterns. If you remember just basic math, by Gemini is 2. So every other beat is a PVC. So a normal beat PVC. In this particular instance, what we're looking at is trigeminy, because every third, 1, 2, 3, every third beat is a PVC. Again, this is because this client has probably multiple cardiac comorbidities. They can be having issues with possibly electrolyte imbalances, issues with their SpO2. You're still going to go through and do the normal things that we would do, assessing our client, looking at the MAR, looking at their electrolytes, looking for underlying causes. And then what we want to do is go ahead and try to correct whichever underlying cause we are associating with these PVCs, if there are any at all. This does put you at a significant higher risk for R-on-T than just having benign ectopy happen randomly. Because as this pushes closer and closer, if it were to happen somewhere around there, we talked about that relative refractory period. And again, that is just when your heart is able to respond to outside stimuli. And if you were to have another beat happen on top of where that relative refractory period is, you could be at risk for R-on-T and then going into a torsades or a defib beta. So we've talked about assessing our client, right? looking at the underlying causes, eliminating the underlying causes, obtaining vital signs. You could give medications potentially, but I'm going to probably assume that most of these clients already have other cardiac comorbidities happening. But typically you may see a carvedilol, labetalol. In more critical care areas, you may see procainamide and lidocaine. I honestly have not seen those used a whole lot, but again, my specialty is not in the ED. What we are familiar with, basic nursing is familiar with amiodarone because it is for ventricular dysrhythmias, or to slow down the ventricular rate and hopefully convert this client to a normal sinus rhythm. So what I see down here in this strip is this client has a lot of issues going on. I'm able to see a bundle branch block. I do see an inverted T wave. I see a very wide and bizarre QRS happens. Not kind of like where I would expect it. It doesn't appear to come early, but it's still considered a PVC based upon its information. And then we do see them start to come earlier from here to here versus how the distance is from here to here. What we have now are two PVCs in a row, at least in this lead, because this first lead is probably different than this second lead. So they're not equal, they're different images of the heart. So this is a couplet. 3 of them in a row would be a triplet. This client does not have triplets. They've got a couplet, then we go back into a normal sinus rhythm, and then they have another wide, bizarre QRS complex. Again, as you can imagine, this is the client's heart trying to tell you that something more significant is happening, and we need to do those assessments, do those interventions as early as possible. All right, so we're going to get into VFib and VTach. And one of the biggest things that I see students struggle with is the difference between a shockable rhythm, an unshockable rhythm, and cardioversion. So I want us to remember defib for VFib. All right, so I see ventricular fibrillation, and you can also defibrillate for pulseless or unstable ventricular tachycardia. So that takes care of our two biggest issues where the client may present as symptomatic, elevated heart rate, blood pressure, respiratory rate, and then all of a sudden they become symptomatic. They become unresponsive, obtunded, however we want to tell you that, hey, this client is no longer stable. So you have to look for those words. You want to make sure that you have defibrillation available. It's the best, remember we talked about semantics, it's the best thing that we can do. If we don't have a AED or a defibrillator, we are going to just initiate our ACLS. And for basic nursing, since we don't really do ACLS, what we're talking about is our CAB, so compressions, airway breathing. For your cardioverted rhythms, what we're going to see is stable VTach, SVT, so supraventricular tachycardia, AFib, and A-flutter. So what I notice mostly here is that 3 of the 4 of these rhythms are in the atria. And I know it's a cardioversion because cardioversion uses less electricity, and with all due respect to your atria, they are less than the ventricles. The only difference is if the client is in a true ventricular tachycardia and they have a pulse and are stable. Again, if you just shock somebody from out of nowhere, it's going to hurt. Make sure you use the pads and make sure that you medicate if entirely possible. And then we do see, again, our normal medications that we would include as part of our ACLS. Again, as from an ACLS standpoint, we're probably not going to ask you questions, but we know we use amiodarone for other things. We know we do CPR. We know we do cardioversion. We know we do vagal maneuvers and Valsalva maneuvers. We know we give adenosine. So if I've stressed it and it's on my little list, then you know it's a testable medication. So again, epinephrine, the lidocaines, the propanamides, those are more ACLS, and I don't test over those medications. I do want you to be familiar with them because some places do still do use them. And then we have our unshockable rhythms, which basically means I can't do anything until I get some sort of rhythm back. So, of course, asystole, regardless of what ER or Grey's Anatomy or any of those other, not so high-speed medical shows tell you, you cannot shock asystole. No flat lines. Flat lines means no shock. And there we go. You will start CPR. PEA. Now, this is the kicker, and this is the one that most new grad nurses probably confuse, is you have PEA, which is not shockable, but you have PVT, which is shockable. And I know even I have talked about one when I was talking about the other one, just because they probably both start with pulseless, and it's just kind of, we get a routine in our head when we're talking about it. But you absolutely cannot shock pulseless PEA. So if it appears as something sinus, brady, or tachy other than VTAC, you need to get a real pulse back so that we can hopefully end up shocking them or converting them into a normal rhythm. So we talked about couplets, and I do see on the far right of this strip that I do have a couplet. But further down to the left of this strip, what I notice is that instead of having 2 in a row or 3 in a row, I have 4 in a row. Runs of 3 to 4, it depends again which book you look in. You can call a run of 3, you can call it a triplet, or you can call it a run of ventricular tachycardia, because that's what that is. It is a 4-beat run of ventricular tachycardia, and you know that rate during that 4-beat run is going to be very fast, because look how close together the QRSs are. Then what happens is you have a compensatory pause over here, and your heart starts beating in a rhythmic pattern once again until we have our next set of couplets. Again, this is probably something that you want to address fairly soon, because again, it's a precursor to worse things happening. A 4-beat run of VTAC can turn into a 6-minute run of VTAC if you are not careful. So we are going to consider these as life-threatening because they can decrease your cardiac output. So we've talked about CAB. That's the big difference. Best first, and then depending on what options, what distractors that they give you. I try not to put defibrillation and CPR in the same multiple choice question format. So choose option A, B, C, or D, because I do think it is very confusing for new nurses if you don't have a lot of experience in an ED or actually doing anything critical care-wise, it can be very confusing. What I want you to understand is that if you don't have a defibrillator, you need to start CPR. And instead of ABCs, we're going to do CABs, which just means for this particular instance that you're going to start CPR first. You can have stable ventricular tachycardia. Remember, we can defibrillate that. And then you can have your unstable. Sustained ventricular tachycardia is going to have a profound effect on your body's ability to maintain homeostasis due to decreased cardiac output, changes in your blood pressure, your heart rate, your fluid volume, pulmonary edema developing. You can have issues because you don't have an effective pump to have issues with anoxia or anoxic brain injury, so decreased cerebral blood flow. And of course, ultimately, they end up in cardiopulmonary arrest. Just remember, people that have an MI typically don't die because of the myocardial infarction itself. The hypoxia leads to a lethal dysrhythmia that is left untreated, and that's usually how they die. You can have sudden cardiac death, but that's more rare. Because of all those potentials, we know that treatment must be rapid, right? We do know that if you've had it once, you're more than likely to have it again. So if you weren't on some medications to help with heart rate or blood pressure or heart failure, whatever it may be, whatever that underlying reason was that you had a bad pump and you ended up in this dysrhythmia, you need to address it and make sure that we're going to do something for that. And then, of course, that V-tach can turn into V-fib. It's not really going to change your care a whole lot, but again, it's just going to refer you back to CAB. So again, we're going to look at our precipitating causes. And we're going to have to find those causes, and we're going to have to treat them. That's what we've already just said. Again, hypoxia is there because it's a huge reason to end up in a dysrhythmia. We've talked about our options for stable. Mostly, it's going to be cardioversion. Let's see. You can use the procainamide again, the sotalol. Again, amiodarone is more in line with what I expect you folks to know. And then you can also have this other thing called a polymorphic ventricular tachycardia, which just means it's twisty-turny, and we call that torsades de pointe. Usually that is because you have a low magnesium, because it is still a V-tach. It's the same medication, it's the same process. So here is polymorphic ventricular tachycardia. You can see that there are some definite changes. So initially our QRSs start this way, and then we see it kind of twist and turn here, and then it goes back to this way, and then more changes here. So it doesn't look like that beautiful thing that you would expect for just ventricular tachycardia. So it's polymorphic, and again, it's coming from multiple areas. This is more of a traditional ventricular tachycardia. In this particular case, we're going to say it's unstable. So ventricular tachycardia without a pulse is a life-threatening situation. And we're going to refer back to CAB. Again, however, if we can defibrillate, we're going to defibrillate. Here we see a 12 lead of ventricular tachycardia. And again, it's not perfect, and no rhythm strip or 12 lead is ever going to be perfect, but I can still see, these wide, bizarre QRSs. I don't see really any P waves. This is the QRS here. So you have an inverted T wave, it has a depressed ST segment, then it comes back up and you have another contrast. I don't know what's going on there. Sorry again. Oh yeah, it wants to do it again. So here's kind of what it would look like on a telemetry monitor. You can see the really fast heart rate. You need to get in there and you do some nursing interventions fairly quickly and make sure you are obtaining a blood glucose, a set of vital signs, SpO2s, all that good stuff, as well as obtaining a 12 lead. Make sure you call and ask for help, get the crash cart, all the good stuff that we've been talking about. VFib, kind of along the same lines, you still have the same clinical associations. The big thing that I pointed out here in red is that VFib tends to happen maybe when the client is getting paced, so external pacing, or the client is down in the cath lab. You guys hear all those code blues, the cardiac cath lab. It's probably because they entered into some sort of dysrhythmia. We have that catheter in their heart, and if it causes some sort of irritation, it can send your heart into these dysrhythmias. It can also happen, so if I give like TPA for a clot for an MI, what's going to happen is that that clot has probably been there for so long, or your coronary arteries have been clogged for so long that when I get rid of that clot via the clot buster, that the oxygen that is now making its way to that portion of the heart kind of actually shocks the heart into this dysrhythmia. Any kind of electrical shock, obviously you have electricity going through you. You're talking about your H's and T's, and you include things like hyperkalemia, hypokalemia, hypoxia, your pHs, your acidosis, your toxicity, tamponade. You guys don't need to know H's and T's. I want you to, again, to have heard the term before, so when you are doing your ACLS, you can kind of figure out what they're talking about. And here is VFib. So, clinical significance, they're usually unresponsive, pulseless, they could be apneic. Obviously, if we don't do something, they're going to die. So we're, again, going to refer back to CPR, ACLS, defibrillation. So, VTAC, VFib, all the way to death. And so if I have a stable client with a pulse, I can cardioversion. Right? Synchronized cardioversion just means we hook it up to your heart. It senses what your heart is doing, and it delivers a shock at the appropriate time. If they are unstable without a pulse, so there's your pulseless VTAC, you can defibrillate. Pulseless VTAC. Still going to include CPR, I still talk about ACLS, medications. But ultimately, if we don't do anything, what's going to happen is they're going to start here, go here, and end at death. So just more information. I already gave you kind of a summary of torsades, and we'll look at it from our lecture standpoint. So polymorphic ventricular tachycardia, it's characterized by twists and turns in the QRS. It's usually associated with a prolonged QT interval. Mostly it's electrolyte imbalances, and the big one that we see is magnesium. Of course, we want to convert them so we can do amiodarone, but amiodarone could potentially also cause torsades to form. Video of sotalol. We can have issues with torsades for your antipsychotics, your antibiotics, your antidepressants, your bradyarrhythmias, and including MI. What I want you to notice is that when we started off early about, oh my gosh, the QT interval and it's going to get prolonged, we listed a laundry list of all the medications that could prolong that QT interval, and that is potentially what is sending them into torsades de pointe. Here's what that would look like from a telemetry standpoint, and see the wide, bizarre, twisty, turny, really fast tachyarrhythmia. Symptoms and complications are pretty uneventful. I feel like my heart is racing, I'm dizzy, I'm having issues with fainting. I hope that they don't develop sudden cardiac arrest. If we don't do anything, it's probably going to progress and they're going to end up with unaliving themselves. Our assessment is that we need to do our measurements of the QT interval. We need to look at our electrolytes. We need to look at our MAR. We need to assess our client. That's really what it comes down to. So if I'm doing that, of course, I want to make sure that I stop any medications that are going to prolong that QT interval. We're going to give a mag run, and of course make sure that they're on telemetry. We're going to correct any underlying electrolyte issues. Talked about giving MAD. You can do a K-run. You can do beta blockers if we're looking at congenital issues. We can certainly try to pace the client into a normal heart rhythm, and then maybe we have to send them out for an AICD, so an automated, and then we have the ICD, internal cardiac or implanted cardiac defibrillator. They will feel something, but it's not going to be as bad as the shock that we would give with the pads. Again, here's our kind of VFib, VTAC. A lot of times I hear these terms used interchangeably, and it's just because they have so much going on in their telemetry monitor or their 12 lead or in their heart rhythm, that they're kind of going in and out of a lot of it. And that's really all you need to know for your ventricular dysrhythmias. Differentiate between a shockable and an unshockable rhythm. Know that we want to correct any underlying issues, and then continue to monitor that client, get them back into a stable rhythm. Pacemakers, this is newer-ish. Didn't talk about pacemakers a whole lot previously because we weren't getting a whole lot of information in the NCLEX test plan about whether or not pacemakers were there. But again, since they updated and we've gone through it more, you do see that they can ask you some questions over pacemakers. I'm going to try to keep it just general and brief, so we know what a pacemaker is. It's a metal device that we're going to implant into your person, and we're going to connect wires on the inside of your heart to your atrias or to your ventricles or to both. We do this because maybe you no longer have an SA node that can maintain cardiac output. You have a long history of Brady arrhythmias, and we want to fix that issue. We've talked about temporary, where we're pacing them externally using the pads, or obviously if they're going to go out for surgery. So typically when we talk about these Brady cardias, what you're going to see is that we're going to lump our bradycardia in with like a secondary type 2. So that's our 2, 2, and our complete or our third degree AV blocks. And those are generally Brady arrhythmias. And those come from heart block. If you do have some cardiomyopathies and have developed heart failure, we can certainly think about pacemakers for that. It's more than likely they'll do some sort of cardiac resynchronization therapy, CRT. And then, of course, you may need it if we have issues with cardiac output after certain heart surgeries, or we feel your heart can no longer be an effective pump. So temporary pacemakers are used to pace the heart during CPR or open heart surgeries. When you have a sinus arrest, symptomatic sinus bradycardias, heart blocks. Can also help correct tachyarrhythmias. And permanent pacemakers are inserted when the heart's natural pacemaker becomes irreversibly disrupted. And in the image, you can kind of see that this client is being ventricularly paced. So I see the implanted pacemaker over here. Start working again. And then we kind of see the wire that is being fed through the superior vena cava into the right atrium and finally into the ventricle. And that's what's going to deliver the shock or deliver that oomph that your heart needs to maintain a heart rate. So for instance, if this client were 100% ventricular paced, it means you would see a pacer spike every QRS complex. And I'll give you an example of what all those look like, whether it's AV paced, V paced, A paced. So again, just our types. You have temporary pacemakers, permanent pacemakers. You have AICDs, which are defibrillators. And a lot of the times you will have AICDs that also have a pacing function. And then you have this biventricular pacemaker, that's your CRT. We talked about when we're going to use a temporary pacemaker. It doesn't really change for a permanent pacemaker, except now we're going to throw that word chronic in there. And then defibrillation will happen, this AICD or ICD, they will call it either or, is to help for clients who've had like recurrent issues with VFib, VTAC. The different types, I have a single chamber, dual chamber, or that biventricular. So the single chamber is exactly what it sounds like. I have a lead in either the atria or the ventricles. Dual chambers, I have them in both, which the image on the right has a lead for the atrium and for the ventricles, so they're AV paced. If it were to be a biventricular resynchronization, what you would see is that we want both ventricles contracting at the same time. And that will help with the CRT, will help to ensure that one isn't firing before the next one, and you typically see that with like some sort of cardiomyopathy, restrictive cardiomyopathy, whatever it may be. You have modes, so asynchronous, so without syncing to the normal heart rate, so it's a fixed rate. So regardless of what your heart does, it's going to give you a set rate. So if my set rate is 80 and my heart is only able to produce 50 on its own, this will give me enough leeway that I have that extra 30 beats per minute in there. So they don't really care what's going on. They just know that you need a heart rate of at least 80. So demand is a little different in the fact that we will set up for it to kind of look at whether or not your heart has the ability to produce its own electrical signal to convert to a mechanical function. What's going to happen then is that we're going to set it up to give your heart time, maybe just a fraction of a second. So if that pacemaker doesn't feel the onset of the next P wave or QRS, whichever one we're looking at, or both, if we're doing AV paced, it's going to wait. It's going to say, okay, I felt that the heart generated a signal and do nothing. And then it'll wait again. Now, on this next one, it waits, and in that given time frame, it does not sense an electrical signal. It will generate one itself. So it's demand. It's based on what your heart is able to do and what your heart isn't able to do. Obviously, you have a big piece of metal in your body now, so if you're going to get an MRI, make sure that it's okay with your healthcare provider. We are seeing more and more pacemakers that are able to tolerate the MRI machine. Don't sit in front of loudspeakers at concerts, and try to avoid metal detectors if at all possible. You want to make sure that you're carrying your Pacer ID card and you have your medical alert bracelet. Every medical TV commercial ever. If you start to have signs and symptoms of ineffective tissue perfusion, ineffective cardiac output, you need to let somebody know, because there are certain issues, and a big one is a lead dislodgement. If it's an AICD, hey, you may feel a mild shock sensation. If you do start to get dizzy, short of breath, whatever, we're going to have you go ahead and sit down because you may be getting shocked. And if you do, you need to call your healthcare provider, and you'll probably schedule some sort of follow-up. And then we want to teach that family CPR, because although an AICD will defibrillate clients, they cannot perform CPR. So if it's not a shockable rhythm, there's nothing the AICD can do. Okay. There are pacemaker problems. These three specifically, you can have a failure to capture, failure to sense, and failure to pace. This is just normal things. A pacemaker in failure to capture will fire, but the heart's like, I don't really care that you fired, I'm not going to do anything. Failure to sense is that the pacemaker no longer understands that you're having any electrical activity, so it's just going to start shooting things off. I'll show you an example. And then failure to pace probably means that you have a battery issue or a connection problem, or maybe you're due for a new pacemaker. When I look at the effectiveness of pacemakers, I want to make sure that they have a stable heart rate and rhythm. I want to make sure that they're not symptomatic, that they're not having any underlying craziness in their rhythm strip. No reports of dizziness, syncope, chest pain, dyspnea. just a normal ECG tracing, with the exception of that we're probably going to end up with some pacer spikes. So, failure to capture. What you see here now is, remember that its capture starts with the C, so the issue is in the cardiovascular system. So here, this person looks to be ventricular paced at the very least. And then all of a sudden here, we don't see that the heart, so the cardiovascular in capture, that the heart has been able to respond to that electrical signal. And so we need to do some investigating, let the healthcare provider know, and then maybe we'll get it interrogated. Failure to sense is exactly that. It makes no sense. The pacer spikes kind of just happen wherever they want. It's our third degree heart block of pacemakers. It's whenever and however they can get through, they're going to get through. So you have pacer spikes that are in inappropriate locations, right? Finally, we have failure to pace. So again, you have the absence of pacer spikes. So we were moving along fine here, and this client looks like they're atrial paced. I see a pacer spike here before the P wave. And then the next thing I notice is this period of asystole, followed with no P waves. All right, so the heart's not going, and the pacemaker is not going. This could just mean that your pacemaker needs to get interrogated, but it could potentially mean that there are other bad things going on as well. For my students, this is nice to know. It's not need to know. I'm not going to ask you a question about failure to capture, failure to sense, failure to pace. If you can look at those three examples and go, oh, I know what a pacer spike is, and I know that it should either be in front of the P wave or the QRS or both, these pacer spikes definitely are not that, then you know enough to do well for basic nursing. So here are different types of pacing. So the first one I'm looking at here is ventricular pacing. As you see, I have a P wave. Looks like you may be right there at developing some sort of heart block. He's like right on the edge. Then I see a pacer spike right in front of that QRS. And I see the QRS fire or contract appropriately. And the problem here is that this person's heart rate is only 50. So I don't know what they have their machine set at, but they might want to consider upping it just a little bit, because the ventricles should still be 60 to 100. We want it to be somewhere around its inherent rate. In B, we have atrial paced rhythm. So you see, I do have this person, it looks like has a chronic widening of the QRS. You can see that it is definitely bigger than one big box. But what's happening here is that the pacer spike is originating the signal, and you have possibly some damage that's causing delays in conduction from the SA to the AV node to the bundle His and bundle branches and Purkinje fibers. So there's more time in there, but I still have a QRS for every pacer spike on the P wave. So PQRST, everything's good. Normal heart rate, don't really have to do anything special. In C, what it looks like probably happened is that somewhere along the way, this client's SA node has failed. Various reasons. If you have MI, heart failure, you could have sick sinus syndrome, just, our body is breaking down as we get older, and my SA node no longer can maintain cardiac output. So we are going to dual pace them. Here you have a pacer spike next to your P and next to your QRS. So this person, because they have it on every QRS, is going to be what we call 100% AB paced. Got another example of that. So yeah, so just two different leads, same client. You still see pacer spikes, and they're both still positive deflections. And they're wholly AB paced until I get right about here. Can't really tell on the other side. But what I do see is that this is kind of that demand pace. So here it waited until you had a P wave, it waited, and nothing came. Okay, now I'll initial a signal, and you have your PRI, then it waited. Okay, I don't see anything happening from the ventricles, so we're going to give it a shot, and then you have ventricular contraction. Whereas over here, it said, okay, I do sense something coming from the atria. However, the ventricles aren't responding, so I'm going to set a pacer spike in front of that QRS. Okay, so just for our ventricular dysrhythmias, I wanted to add on kind of this refresher. I don't care that you know classifications. I know that's strange coming from me. I think that there's already so much going on with our medications and cardiovascular system. I'm highlighting the ones that you must know. So for me, you must know amiodarone. Notice it's not in purple. Notice again, we've talked about the fact that amiodarone, we give it a lot for AFib, A-flutter, but they have that really fast ventricular response, so that we can give it for, and if you look up the indications, it says it's for ventricular dysrhythmias, but we do use it for conversion of other tachyarrhythmias. Side effects, the big one for us is obviously you're going to have changes in cardiac output, which could end up with issues with hypotension, bradycardia, photosensitivity is going to, but pulmonary fibrosis is a huge one. Long-term use, PO, amiodarone, 200 milligrams, 400 milligrams, whatever it may be, you can end up with fibrous tissue in your lungs, which is going to make any respiratory issues that you have significantly worse. Just be careful using it in clients who already have a AV block. Don't know why we'd be using it for that client anyway. And then you have your nursing considerations, which are pretty consistent. And again, my big one is it's a cardiac test. You need to have them on continuous telemetry. Otherwise, how am I going to know that that medication is effective? You're going to do a bolus first, so you want to make sure that you're getting that medication in. Usually it's about 150 milligrams. And then here, the only other thing that it really talks about, and I don't expect you guys to know this for testing purposes, but we do want to ensure that we give amiodarone with a filter. I know sometimes we kind of like to think deep about why we do these things, but basically I want to give it with a filter because it's a very viscous drug. It causes a lot of issues. I would prefer to give it through a central line if entirely possible, but a lot of times that's just not possible. So just be careful and make sure that you are assessing those IV sites frequently, because what's going to happen is that they're going to have that medication, it's going to leak out into their subcutaneous tissue, and then they're going to develop these huge wounds. Right. Again, I said I just wanted you to be familiar with the words, lidocaine, procaine, amide, so those two basically are the same. You see the sodium channel blockers, and then sotalol, which is a beta blocker, but it also has some other properties. So for that page, we need to know amiodarone. It's nice to know the other ones. Here, we're looking at epinephrine. And I will tell you guys that if you don't know anything else in a code situation, no CPR and no epinephrine. Again, that's going to be an ACLS drug, so I won't ask you about, oh, it's 1 milligram every 3 to 5 minutes. But hey, we're coding a client and we've administered epinephrine. How do we know that the epinephrine has been effective? And those are the things that we're going to look at. So make sure that they're on continuous telemetry, make sure we're getting vital signs, checking for perfusion, so cap refill, whatever it may be. So epinephrine is important, however, it's still just an ACLS drug. Mag sulfate, we're going to typically give a mag run for people who have low magnesium to reduce their risk of polymorphic ventricular tachycardia or any other electrolyte hypomagnesemia arrhythmias. You can have some toxicity. We do run MAG almost as slow as we would run potassium. So usually what we're going to administer is 1 to 2 grams, and it's either going to be in a 50 milliliter bag or a 100 milliliter bag. And I know this says over 5 to 20 minutes, but it's talking about IV in a code situation. If we're going to give MAG for basic nursing, it's going to be over a couple of hours. So if I have 1 gram in 50 milliliter bags of normal saline, then my rate is going to be 25 at the very least. We do want to make sure that we keep calcium gluconate available to help if we do have any other issues while infusing the magnesium itself, just because calcium gluconate helps protect the heart. That's one of the big nice things in the cardiovascular system is it's still the same 3 electrolytes that we've been talking about all along. It's calcium, it's magnesium, and it's potassium. And that is it for ventricular dysrhythmias and pacemakers. If you have any questions, feel free to ask me during class or shoot me an email.